Hello, everyone, and welcome to the second in our series of Chesapeake DHX Digital Health Huddles, presented by Anchor Ventures. I'm really excited to have everybody here today for what is going to be a really exciting event with Emocha. It's our fireside chat, and as you can see, we have some real fires for you. I'm Jasmine McNeil. I am a program manager for Chesapeake DHX. I also work with the Johns Hopkins Medicine Technology Innovation Center. And before we jump into our program, I wanted to talk to you guys a little bit about some rules of engagement for today, some ways that you guys can interact and make the most out of today's webinar. So one thing I wanted to point out is that we encourage chat. You can chat to just the panelists or you can chat to everyone. Please introduce yourself, tell us where you're from, share your LinkedIn profile. It's a really good way to connect with folks in the digital health community. Another thing I wanted to point out is that we will be welcoming question and answer today. So you are more than welcome to share questions, and we will try to get to your questions at the end. And you can actually upvote questions in the Q&A section at the bottom of your screen. We will also have polls that will be launched periodically. They are anonymous, so we're not tracking who's answering what. But it's a good way for us to get a gauge on who's here in the audience and what's going on with what you're thinking about some of the discussion topics for today. And finally, the best presenter or the best view for viewing the presenters today, I would recommend gallery mode if you are familiar with different presenter views. There will be no slides shared today during this discussion. And I also would recommend that you hide non-video participants. So we will have a few others online that are not speaking. And so if you see that little 3-dot mark in the upper right-hand corner of that box, you can actually click on that and scroll down to hide non-video participants. It'll give you the best view of our speakers today. So what's going on with the event today? We'll be telling you a little bit about Chesapeake DHX, which is, again, the initiative that's hosting this event. We will be introducing you to our speakers. We will have a robust discussion as well as I mentioned, question and answer, and then also talk about what's coming next. And with that, I would like to actually present to you our program director for Chesapeake DHX, Mark Comiskey. I'll pass it off to him to tell you a little bit more about the initiative.
Thanks, Jasmine. I'm so happy to be sponsoring this event with Anchor Ventures and pleased to see the speakers here today. I'm also happy that Anchor Ventures is a partner with us in the broader efforts I'm leading with the Chesapeake Digital Health Exchange, or CDHX. CDHX is a 3-year effort funded by the U.S. Department of Commerce to improve the Chesapeake regional ecosystem for digital health. We are fortunate to have so many great assets in the Chesapeake region that make it a unique place for digital health. First, we have a highly talented and technical workforce. We have leading university researchers, world-renowned medical centers, major government agencies, including the NIH, the FDA, and the NSA, which is pertinent here, a unique healthcare reimbursement model that's unlike anything in the country, broad support for entrepreneurs generally, both at the state and the local level. Our goal at CDHX is to make it easier for digital health startups to thrive in the Chesapeake region. We do this by organizing to make meaningful connections among startups, investors, customers, and strategic partners. We actively seek companies in the space and hold events, now online, to highlight digital health successes and to connect the digital health community. We work with other universities, other incubators and accelerators, and strategic partners to leverage resources already being dedicated to complementary efforts in the region. We market the region to attract outside capital, startups, and jobs, and we support job training and a diverse workforce development effort. For further information, please go to our website, chesapeakedhx.org, and sign up for further information. Thanks to all of you for being here with us today. And now I'd like to introduce our speakers. First, Sebastian Seger is the CEO and founder of Emocha Health, the leading company using video for directly observed medical adherence. Sebastian's a serial entrepreneur and with global experience and a graduate of our own Carey Business School. Neil Davis is a good friend of mine and perhaps one of the best connected people I know in the Chesapeake entrepreneurial community. Neil has a number of years of experience in senior positions at some of the leading incubators and entrepreneurial organizations in the region. Prior to that, he spent over 30 years in private sector in engineering and business development roles in both domestic and international settings. Neil and Sebastian, it's your turn. Take it away.
Excellent. Thank you very much for having me, Mark, and thanks also, Jasmine. Great opportunity for Emocha.
Yeah, I want to reiterate that, Mark. Thanks a lot for the introduction, and Jasmine, thank you very much for setting this all up. We haven't got a lot of time today, so we want to cover a lot of ground. I do think, though, Sebastian, it's worth taking a few minutes, since we aren't exactly sure who's on the call, what their backgrounds are. It might be worthwhile level setting the Emocha story for the audience. So if you wouldn't mind, maybe drill down into what Mark has already said about you and tell us a little bit about the background story, the origin story, how you came to be leading Emocha.
Sure. So Emocha, the Emocha story actually starts in 2007 at Johns Hopkins, way before I met the docs who had invented Emocha. So it was a university platform for mobile digital health collection in research studies that was invented by Dr. Bollinger's group at Hopkins. And they were deploying mobile applications as far away as Uganda to capture research data out in the field. I came to the Carey Business School in 2011, having sold my last business in 2010. It was a coffee shop chain in Munich, based out of Munich, Germany. I wanted to be in healthcare. My whole family's in healthcare. I thought that that would be the most fulfilling next venture. And I was looking for the biggest problem I could find. And that turned out to be medication non-adherence. So people not taking medication properly. Met the group at Hopkins, and they weren't doing exactly what I had identified as the biggest problem I could see, but they did introduce me to Baltimore City's health department. And there I found out that there's a process that secures really high rates of adherence. It's called directly observed therapy. It's when you have a medication appointment every day. And every public health department in the country does that. And typically over the last 4 decades, it's been fulfilled in person. So we thought that we could use the Emocha platform to deliver directly observe therapy in a novel way.
Great. So when was Emocha, as it currently exists, actually founded?
So we founded Emocha in January 2014.
Mm-hmm.
Hopkins partnered with Dream It Health to start to do an accelerator program in Baltimore, and I think they ran 2 cohorts through that. So we were part of that first cohort in Baltimore. Launched in January. We were live in Baltimore City by April, and then live in Harris County, Texas, by September. So we got a fast start.
I'd forgotten that you all came through Dream It Health. I saw just this morning that Tissue Analytics, one of their second cohort companies, was acquired. That was really kind of fun news to see on a Thursday morning. So that's great. That's a great origin story for you. Now, how about just giving us the thumbnail sketch of what Emocha looks like today? How many employees, 2019 sales, how much money have you raised? Stuff like that, the basics.
Sure. So I'll tell you about Emocha until, let's say, February of this year.
Great. Good.
So we closed 2019 with sales at around $2 million per year, excluding grant dollars that come in from the NIH. We've raised $2 million in seed funding, but that small amount is we're lucky because we've gotten about $6 million from the NIH. It's a great great thing about doing business in Maryland. The proximity and the relationship with great academic medical centers has helped us secure that kind of funding for validation studies.
Great.
As of February, we were about 25 people, mostly Baltimore based.
Right.
Yeah. Is that a good snapshot?
Where's the company located?
So we were in Fast Forward for a while, but we moved out a little over a year ago. We're based in Mount Vernon.
Oh, okay, great. Good. So you're a Baltimore-born, Baltimore-bred company.
Exactly. And I'm also Baltimore-born. Grew up here, went to high school here, left for a very long time, and came back.
That's a great story. Really good story. Thanks a lot. So let's see. If my memory serves me well, going back to 2014, 2015, when Emocha first launched, you were focused, I think, exclusively on helping local public health departments in the medication adherence space. That's basically correct, right?
That's right. And today we serve over 300 public health departments across the country.
300. Okay.
They'll use Emocha for a very small group of patients who have tuberculosis. And for tuberculosis, the standard of care is direct observation. So they use Emocha to observe every dose of medication that they take. Okay.
So going into the end of 2019, those revenues you told us about, I'm assuming were exclusively coming from that customer base. Is that accurate?
Well, I'd say that that was our main customer base until 2018. In 2018 and 2019, we launched a service. And so we were a software until 2018. And we launched a service because hospitals and payers are not going to watch a video of a patient taking their medication every day, even if it sounds like a great idea, even if it would have cost benefits. They weren't going to do that. So we first added healthcare workers who would do that on behalf of the payer or the health system. And then we added nursing. And then finally, last August, we completed the puzzle by adding pharmacists. So through our partnership with the University of Maryland School of Pharmacy. So our revenues in 2019 were about 80%, let's say 70% public health departments, about 10% researchers, and then the growing section was 20% of health systems and payers that were just, these pilots were getting underway and gaining traction. Okay, so we had a great start to 2020.
Okay, so it sounds like the growth potential going forward for Emocha is going to come from that service you launched.
It's going to come through the service, and it's going to be health systems and payers.
Gotcha. Okay.
Reducing costs for patients when they take their medication, do much better, need a lot less healthcare.
Makes sense. Okay. So let me ask you this. So entrepreneurs hear all the time from all varieties of advisors and big thinkers that they have to be constantly aware for opportunities to pivot, either for strategic reasons or in response to what the marketplace is telling them. So always be ready to pivot. Thinking about Emocha's development, say from 2014 up through the middle of last year, is that a strategy that you applied to Emocha's development?
Oh, continuously. So just the fact of our first launch at LifeBridge Health for patients with congestive heart failure, that might have been late 2017, when their nurses they loved the platform, but they just couldn't keep up with, if they had 30 patients submitting videos every day, they couldn't keep up with it. So, when you encounter a problem, you either have to walk away and decide to leave that line of business, or you have to figure out what's going to make that line of business successful. Right. That turned out to be quite complex, and it took us 1.5 years to get our service lined up. But now, at this point, it is a real turnkey medication adherence solution. Now, what we were confronted with at the same time, companies need focus. So sometimes just, things not working, you just have to be persistent and keep hammering away. Right. Because if you keep pivoting 1 million times, your team goes crazy and they can't keep up with, a quality organization can't keep up with too many different, different pivots.
Do you have a couple of examples of maybe some other pivots that you guys went through beyond the LifeBridge pivot? Maybe
I'll tell you one that cuts both ways.
Okay.
So we launched our product. This is 2015. Launched our product. We're dedicated to medication adherence. We had, we're leaning on this age-old, 40-year-old process called directly observed therapy. And the state of Maryland comes to us and says, listen, Ebola is a massive crisis in Africa. We would love to use your platform to monitor for symptoms of travelers coming in to Dulles Airport that are going to land in Maryland. So we said, yes, absolutely, we'll do this. Huge success, monitored, over 1,000 people who were coming into the state. And then, the next year, Hopkins asked us to monitor healthcare workers in their biocontainment unit for all sorts of highly infectious diseases. And it's symptoms monitoring. So we did that. And along the way, there have been a lot of discussions. Look, it's this one customer. Now we have 100 customers. Can we continue to do this and maintain quality in our platform? And then all of a sudden, COVID comes along in January, and then we realized, well, look, actually, the reason you do some of these things that are related but not exactly what you do is because sometimes they become very important. Yeah. So there's a pivot that we made back in 2015 that served us very well for 2020.
Interesting. So it sounds like the pivots that you made up through, say, the middle of 2019, late 2019, were really customer-driven pivots, right?
Yes, absolutely. So every time we really believe in what we do, we know that there is validation. There's years of research showing that what we do works, but the platform to deliver that has to evolve. And those little pivots are what make the platform valuable. We've baked in all these little learning experiences and failures into what today is a very, very solid product.
Great. Okay, so let's roll the clock back a little bit to last fall, okay? The economy was strong. Unemployment was at an all-time historic lows. The stock market was booming. We were seeing signs of average hourly wage growth after a couple of years of not seeing that go up. How, at that time, back in November, December, how were you feeling about 2020 and 2021 for Emocha?
Yeah, I mean, I felt great. We had these, we were gaining traction in the public health markets. We were getting public health department after public health department, hands down the market leader. But more importantly, our growth story is going to come from payers. And we had just signed on a couple payers, a couple health systems, felt really good service could actually get out of the public health domain and into the, let's say, the readmissions prevention market, cost containment market for payers, for vulnerable populations that are also quite expensive. So we felt really good. We have a great team, a very solid team. It had grown in 2019 from about 15 people up to 25. So So yeah, we were poised for doing another round of funding and really being aggressive on outbound outreach to new customers.
What about, so at the same time, back in, let's say, Thanksgiving, November, December, you were super optimistic about the future. What about competition? Are there companies out there that were causing you concern that do what you do? Were there competitive alternatives that the market was considering? What about the competitive side of the situation?
Sure. So the company that does very, similar things to what we do is AI Cure, which is a full AI version of what we do. No human beings involved. We really believe in the human connection because we think that part of adherence is not just whether people do what they're supposed to do, but if they experience side effects or symptoms during a course of medication. And a lot of times you can capture that in a questionnaire, but sometimes you need to see how the patient looks or listen to them. And so that concept decided to dedicate itself to clinical trials, right? And so in our lane, which is the real world, we felt like we were in a unique spot with only one or two other competitors in general. On the other hand, remote patient monitoring, which is what we do, remote patient monitoring, had the rules on reimbursement had been loosened and broadened by CMS. So we also felt that for the same thing that we do, there are competitors out there that do something different, but it achieves the same end goal. So I think there's a lot of competition for remote patient monitoring, not as much for medication adherence.
Okay. And you feel like you've got some really interesting competitive advantages over those alternative solutions.
Absolutely. We have a way to lock in medication adherence for really big pieces of the population. We can activate people into the system very reliably, and we know how to achieve an end result. We're a little bit more expensive because we throw human power at that. But at the same time, that explains why a very high proportion of patients will first activate to Emocha and then stick through the program.
I see. So it's a sticky solution. Okay.
Yes, extremely.
All right. So Thanksgiving dinner, great dinner, really enthusiastic about 2020. New Year's comes and goes. And now we're getting into February and we're all watching the news and following the events in China to see what's going on with COVID-19. Do you recall when you first became aware that this was not going to be a business as usual situation?
Yeah, so let me preface that by saying that Thanksgiving in my house starts at 10:30 with a big tenderloin because it's Argentine American Thanksgiving. So we do the tenderloin at 10:30, right? And then we do the turkey at about 4 or 5. Okay. So we do have by 6 you're all asleep, right? Okay, that's good. That's good. Right. Our advisory board is mostly infectious disease experts out of Hopkins. The inventors of the original Emocha platform, Dr. Bollinger, Dr. Chang, J. Mackenzie White, are all public health focused. So we saw this one coming in January. They were telling us, listen, whatever you're doing, and remember also that we do serve the biocontainment unit. Yep. So we were getting concerning calls and emails out of Hopkins in early January. By late January, we had been asked to expand what we were doing to cover more of the hospital because we were limited with this healthcare worker monitoring. We were limited to the biocontainment area. So yeah, I would say that the world started to look different end of January, and understandably, there were some very tricky conversations internally at Emocha because we're going all cylinders on medication adherence, getting great traction, great conversations everywhere because we'd had first results and they're all great. So, at that point, part of the company said, listen, we just got a couple purchase orders dropped on health departments. They're big money and they're for monitoring of people who might have COVID. And then, the other half of the company saying, just, push that to the side. It's medication adherence. Just focus on this. By mid-February, it was clear that this was going to be a big problem. And the company had rallied entirely to say, look, one way or the other, we are very well positioned. We are experts in monitoring for symptoms. And we should step up and help those, at least those in our network who know about us, who rely on us to solve their problem. If they perceive it as a problem right now, and if this could really be a very big public health risk, our roots are public health. Let's go now. So that decision was taken by about mid-February.
Tell us a little bit more about the kinds of customers or users who were coming to you in that January, February timeframe asking for help.
Sure. So there are public health departments who wanted to, this is actually, I'll try to be as short as possible. We've got public health departments who realize they would not be able to do in-person activities regardless of disease state. They want to transition their healthcare workers to remote platforms. Some of those would be telehealth live stream, not us, and others would be Emocha for remote monitoring in a fast virtual manner, asynchronously. Then we had public health departments who know that they have the obligation to monitor pandemics. So a COVID positive case plus all their contacts after they trace the contacts. So assistance in contact tracing was the second use. And then the third one was healthcare organizations seeking to monitor their healthcare workers who would be the most vulnerable. At the time, we thought that healthcare workers would be the most impactful. This is in mid-February, and we decided let's just focus on that. So we rolled out, after many conversations, we rolled out all Hopkins hospitals and all LifeBridge hospitals, and then several other smaller hospitals and Cedars-Sinai with a healthcare monitoring software and service, because these organizations they have all sorts of other things to worry about besides, digital monitoring. So our service team stepped in to do that monitoring.
Okay. So I want to get to I want to get back to what you mentioned a few minutes ago about the conversations that were going on internally with the team while all this was happening. Before I do that, I want to just back up a little bit to January, when your advisors began to sort of put this on your radar screen. At the time, were you all seeing it as a threat, an opportunity, or a blend of both of those things?
So I think that we personally felt that it was a threat as people. And I think from the business side, the sustainability of the business, our customer base is public health departments. I think that had we been an event management company, we'd be business-wise very concerned. But we're a public health company, and so we felt that it wasn't really about whether we were going to survive or not necessarily, but it was more about, do we continue down the public health path that we try? We love our public health customers; they're the greatest people in the world, really. But there are smaller dollars in public health departments in general, traditionally. So we really wanted to focus and keep our momentum going with the larger implementations. So it was really a choice of where to focus. And so that was the concern. We didn't feel at the time sustainability concerns. Now, as the crisis grew and business began to shutter and you hear about layoffs, then you really do start to worry about supply chain type of issues, or, well, who does pay for these customers? But in the end, it turns out that our position just happened to be a position where we're needed the most now.
That's great. Okay, so let's talk about this. This should be interesting. So tell us a little bit about the conversations you would have in your staff meeting with your leadership team in that January, February timeframe about this opportunity, this new potential situation that was coming along. What were some of those conversations like? Was there conflict there? Was it easy to gain consensus and get the team all on board? How'd that work out?
Yeah, to be honest, there were, I'm very proud of the team that I have. Everybody in our company, really, really smart people, and very opinionated people. which is it's a great. It's got its pros and cons, but mostly it has pros. We get
Right.
some very passionate people at Emocha. The opinions were all reasonable and all very different. We worked so hard to get to where we were at the end of 2019, both in terms of the product, the service offering, relationship with the School of Pharmacy, and having integrated nurses and pharmacists. So, to really then go down a slightly different path. So just to give you an example, this comes out of the history of these disease states. Ebola had a 40% death rate, but a very low transmissibility. COVID-19 appears to have a very low fatality rate, but a very high transmissibility. So obviously more people die from COVID than from Ebola in the United States. But the thinking had been, this is a different workflow. This is so different. It's just going to affect a few people. So there was that thinking. The other thinking was what our infectious disease experts were telling us. No, this is a major problem. This is so far beyond the scope of Ebola in terms of like transmissibility that the reaction is going to have to be major, and you're talking about large volumes. So just as an example, we rolled Emocha out to 30,000 employees at Johns Hopkins about 3 weeks ago, right? That is a lot of people. That's different than monitoring 500 people for medication adherence at a time, when you can enroll them over time. No, in this case, you got to enroll people now. When you talk to customers, you have to spin them up tomorrow. It became a different world very quickly. So internally, the pressure, the disease, it's really the disease progression into the US changed everybody's mind and got everybody on board. Got them on board in two ways. One, this is better for the business to focus on this. Two, as people, we want to help. We want to be valuable at this time. And we want to help our colleagues, that we work with, and our partners, and, our customers. We want to help them.
Gotcha. Okay. So let's talk more about the pivot and the product and service offering you have now for COVID-19. So what's the user narrative like? What's the product and service like? Kind of walk us through that Emocha service offering that you've developed just in the past month and a half.
Right. So a working version has been in place since 2016. The version was very similar to our medication adherence product. At the time, the CDC had imposed a requirement that you do a temperature check in person on people who had been infected by a very deadly disease. So we had the video piece in place as well. So, over the beginnings, every single person we enrolled in Emocha, it was healthcare worker monitoring. We would take a video of themselves taking their temperature. As we got from 30 people exposed to COVID, and we do a symptoms capture as well. So do you have symptoms? Yes or no? Enter your symptoms. If you are symptomatic, so now we take a video only if you're symptomatic. We ask a couple risk questions, and then after that, on the other side is probably that's the very easy part. For the user who's entering symptoms or not entering symptoms, a very easy process. You can chat with our team. You can ask questions. There's a lot of questions being asked, a lot of confusion, a lot of uncertainty, even among healthcare workers, and our team answers. But more importantly, for occupational health, they have an overview of the whole population. They can see 30,000 people. And here's the really comforting thing. Out of all these people, there's only a very small portion that have very concerning symptoms. That's very good news. And they can see only that list, and they can engage in some automatic ways and some non-automatic ways with these people who need the help. So that was the COVID product. So the COVID product started as video observation. Then we got the video out for those who were asymptomatic. And now in the last few weeks, as we've gotten probably 5-6 requests a day from large employers to monitor return to work.
Oh, yeah.
So today's status is either green or yellow. Green if you're asymptomatic, yellow if there are concerns and you should not be in the workplace.
Okay. So what's the So what's the form factor? What's the user experience like? Not for the customer, but for the individual who's using the Emocha app. Is it a smartphone app? Is it a what's that experience like?
It's a smartphone app.
Yep.
You download the app. It's not a web app.
Mm-hmm.
You receive an SMS or email for enrollment that has your user ID, so it's pegged to you. We're fully following HIPAA.
Yep.
They download the app, set their password, and then they're in a monitoring period. For the purposes of people who are exposed, that monitoring period is a 14-day period. So we track them over 14 days. And then they're off. And then Emocha is available. We are seeing some people who, at that point, even though their monitoring is done, even though they have nothing to do, will then log back in and report that they have a symptom. In the employer use case, the monitoring periods are longer, and they begin 7 days before the return to work.
Okay.
So when employers are trying to figure out who can come back, they need to know in advance who should stay home until they've had several days symptoms free.
Okay. And what does that revenue model look like for an employer who wants to monitor his or her returning workforce?
Do you mean our cost model to them?
Right. Yes.
Right. So this is all in flux depending on,
Sure.
how they're implementing. But in general, we're rolling this out just to be as fast as possible, and it is generally inexpensive. The setup is about $5,000, and the per employee we're charging a certain amount per month depending on the complexity.
Okay, so the PEPM model. Okay.
Yes, and it's a PEPM model. It started out quite expensive because we were doing monitoring on every single person, eyeballs, humans. With automation, we've gotten it down into the single digits per month.
That's fantastic. Great. Okay, last question in this sort of area. I think I know the answer already, but I'm going to ask it anyway. Have you taken advantage of any of the federal, state, or local COVID-19 related assistance that's available to companies?
Absolutely, yeah. We took advantage of the federal grant dollars that were available.
Yep.
That require you, in order to be forgiven, they require that you maintain your head count.
The PPP loan.
Yep, the PPP.
Great.
I felt that even though our business was stable, fact of the matter is that we are venture backed and we, we're not profitable, and therefore raising money could be a concern at this point in time. So in order to hedge against that, we did take the PPP. Great,
makes sense. Good. Okay. I've heard you've mentioned this twice now, and we had an audience question come in from Mark. You're collaborating with the UMB School of Pharmacy. What's that all about? You mentioned that twice now, Sebastian.
You cannot monitor medication adherence if you don't know what the patient is taking, if the patient doesn't know what they're supposed to be taking, and if they've got all sorts of drugs in their cabinet that they have no idea about. So the School of Pharmacy, they have an e-health center. Before we start a medication monitoring with a patient, they will get on the phone and clarify the regimen. Are they on the right medications? Are they confused? Do they understand their regimen? Do they have any suggestions for the primary care provider for altering the regimen for this particular patient? In other cases, the medication itself requires a clinician to give advice on technique. For example, an inhaler for asthma. A layperson should not tell a child how they're supposed to close their mouth around an inhaler. So the School of Pharmacy helps us by providing that clinical advice to the patient directly. In some cases, we'll use a nurse, but sometimes we use the School of Pharmacy.
Okay, great. I think I'm guessing a lot of our audience members would be in a similar situation, but can you share a few best practices or lessons learned that you've stumbled upon concerning company-university collaborations?
So are you meaning in terms of the commercialization sense, or do you mean university as a customer?
Yeah, no, the interacting with the university as a collaborator, like in the case of the School of Pharmacy. Yeah, as a collaborator.
Well, yeah, I think one thing I've learned is that, I originally thought of Johns Hopkins, as like a big university, or University of Maryland as a big university. And these are very, very large institutions, and you have different, obviously, very, very many different functionalities, especially when it comes to healthcare.
Right.
You have to understand, are you talking to a researcher who is running a research project? Are you talking to someone involved in the delivery of healthcare? So I think that it's important to not blanket an entire major institution with any one strategy. You have to understand the person that you're approaching. And you have different, by working with different people, you get different benefits from it as well. So
Sure.
it's amazing to have your technology validated by world-renowned researchers. It's also really incredible, an area of hospitals I never knew existed really, or wasn't that aware of, occupational health. They take care of the health of, of all these employees. It's amazing. At the same time, I feel really sad for these people. They have to take care of people they take care of the people on the front lines right now.
Right.
It's a massive undertaking. So you really have to know who you're talking to.
So really not to oversimplify, but it's really basic, old-fashioned basics of knowing your customer, right?
You have to know who you're talking to, and you have to know what they care about.
Okay. Do you see are there any collaborations that you can share with us that might be not in the works, but in the, that you'd like to see put into place over the coming year with university partners or other partners?
Well, we've just launched an amazing partnership in Washington State through the University of Washington with a methadone treatment center. For methadone, the standard of care is direct observation in a clinic. As you can imagine right now with COVID, patients with addiction are not going into the clinic, and therefore they've got a lot of take-home doses. That's great for some. Others would really benefit from the structure.
Sure.
What I would love to one of my goals in the very near term are collaborations around how can we best treat patients outside of the hospital when we get, let's say, a little wary of traditional telehealth, right? So right now, the market is adopting telehealth so rapidly. It's really incredible, and it's a great thing. The regulatory entities in the US are playing their role as well. But in public health led the way here. In the 1990s, they were using those wall-mounted video phones to do directly observed therapy on patients who were remote. And public health adopted technologies like Emocha when those live technologies wouldn't scale. If you're delivering care to millions of Americans, you just can't and shouldn't have a live interaction with every single patient. So I'm excited for the asynchronous video opportunities to deliver very small bites of healthcare in very efficient ways. So, and looking forward to working with hospitals and payers on that.
Okay, good. We're getting a number of questions in. I want to bundle them all up into one and then move on. What about the team? Are you finding are you having to scale up the team, add people? If so, what kinds? And are you having trouble finding the right people?
Right. Yeah. We went from 25 in early February to about 50 in late March.
Okay.
A lot of these people were on our services team. We did double our engineering team. Our product team has had additions. Our sales team has had additions. I don't think that we're having, it's never, at this point, it's not a problem to hire, but obviously you want people who share the mission, which is really I believe our mission is really to help the most vulnerable people, and do that by getting them high touch in very, very tiny doses, very efficient doses. So we need people who align with our mission, which has its roots in public health.
Gotcha. Okay, good. I'm watching the clock here. We're doing great on time. I want to ask you one more question before we jump into the ever popular lightning round. So, my last big question though is, raising money is a common theme, I think, of every Anchor Ventures event. It always pops up sooner or later, beginning, middle, or end. You said earlier you've raised about $2 million in seed money. Were you able to raise that money locally?
Mostly, yeah. I'd say it
Good.
was about half local and half West
Mhm.
Coast.
Okay. And did you find it to be overall a positive experience? Was it an easy sell to investors to talk through the Emocha story?
Not at the beginning.
Okay.
I think it was, I even myself, the idea that people would video themselves taking their medication seemed
Hmm.
absolutely ridiculous.
Yep.
But here were some very smart docs telling me it's not. So I think it was a hard to believe story at the beginning. A few people jumped on then. I'm so
Hmm.
thankful. And it's been a positive experience because they've been patient. We're 5 years in now.
That's great.
So then, and I think that the second round where we brought in Kport Capital and TCP Venture Capital
Hmm.
and some really prominent angel investors in the area, yeah, then I thought, look, we've developed some traction. Here's a nice story, and I think they like the public health angle as well.
Hmm.
Right now, yes, I want to go raise money and show investors that, look, we're at this stage where we could just really build a massive business right now.
Hmm.
It's a very exciting time where we can not only increase our customer base, but we can help a lot of people in a very meaningful way.
That's great.
So it's been a positive experience.
Good. So you've been doing this for 5 years. You've been successful at raising money. What do you expect the balance of 2020 to look like from an angel VC perspective? Will entrepreneurs in general be facing a tougher time than they were last year, or don't you think so?
Yes, I think so. I mean, vast sections of the economy are right now really
Hmm.
struggling. I think that VCs, they have different portfolios, and who knows what's in those portfolios that'll
Hmm.
probably affect how confident they are in investing right now. I think that others, if you're in digital health though, wow, I mean, what an amazing place to be.
Good point.
What a great place to be an entrepreneur right now when things are changing radically. I jumped into healthcare due to the Affordable Care Act.
Hmm.
When you have massive change, you have great opportunities to step in and do things differently, whereas the entrenched players have trouble making adjustments.
Okay. So I'm sure your team has all kinds of free time on its hands. Any thoughts of expanding internationally? Are there any opportunities, outside of the U.S. that you're excited about?
We should launch with Abu Dhabi, the Emirate, in about 4 weeks,
Okay.
6 weeks.
Okay.
Things slowed down due to COVID, but we're back
Sure.
on as of this morning.
Great.
We are the standard of care for a lot of other international, let's say, individual projects here and there. City of Barcelona, numerous customers in Africa.
Great.
I think that at the moment, the U.S. market is the most interesting for us, where you have just you really have an entrepreneurial spirit here in the U.S. and a willingness to try new things.
Okay. So it sounds like you'll be opportunistic as it comes to international opportunities.
Yeah, but careful as well. Abu Dhabi
Yeah.
required an on-premises installation.
Oh, yeah.
And it was a hard decision to make, but we decided that it was really advantageous given our partner, which is Seha. And we thought, look, we're going to do this because the partner's awesome, but not because it's Abu Dhabi or it's international.
Okay, great. All right, that's great. I'll tell you what, let's jump into the lightning round now, and then that'll leave us a little time at the end for some more audience questions. So I've borrowed these questions pretty shamelessly from Barry Ritholtz's Masters in Business podcast. So if they don't work out too well, it's going to be Barry's fault. So I assume you have some free time, and you might be watching some TV. What are you streaming right now for entertainment? What do you like?
I'm going to have to tell the truth.
Okay.
So I do enjoy Chicago PD. I find it relaxing when they break the doors down, and I'm totally against the police doing things like that, but it's a good break.
Okay, that's good.
I also like Argentine cinema. I think they're a little bit dark. So you watch these really dark movies that are a little bit depressing, but then you come out of it and you realize, hey, I'm in Maryland right now. This is
right.
Life is great.
Good. Okay.
So
great.
So that's what I'm watching right now.
What are you reading right now? What's on your bedside table, or what are you hoping to read over the course of the next month or two?
Yeah, I always like to have Irrationality in Healthcare by Professor Douglas Huff, at our School of Public Health. Whenever you need the answer to the question of why did that happen,
Right.
then you can look at Irrationality in Healthcare, which is, explaining why people make certain decisions, a lot of behavioral economics.
All right.
The last I looked, it was sold out on Amazon, so you might want to get on the waiting list.
Okay, sounds good. Looking back over your career, did you have a valued mentor? Who was it, and why was that person valuable?
Yeah, I've found that over time, it's just so important, and there have been many at different stages.
Mm-hmm. Sure.
It's when you find somebody who's expert, but who's also has the mentality that they're willing to teach,
Mm-hmm.
and you can park all egos. You can get really great learnings out of it. So I was in Germany. I was trained by a controller of a company to do. I was a lawyer. I had no idea how to run a business, and this very experienced controller taught me Excel and how to do, how to manage the entire company in Excel, even as we grew to many locations. In Baltimore, I've found that Dr. Bollinger is a great mentor, the original inventor of Emocha. On our board, I have Dan Roche, who I lean on all the time. He's a mentor in residence at Johns Hopkins.
Right.
And I'd say I have very many mentors
Great.
who I'll reach out to just when you get stuck. And even I'd consider some colleagues, some other entrepreneurs, I'd consider them as mentors. Nick Culbertson from Protennis.
Yeah.
He's on I think it's his first company, but man, that guy knows what he's doing.
Yeah. Smart guy.
So when it comes to investors, I'll lean on Nick.
Mm-hmm. Good. Okay. I'm sure we have a lot of people on the call today, maybe younger folks who are considering joining a startup, either as a founder or a co-founder or as an employee. What advice would you give that individual based on your experience?
Right. So every startup is going to be very unique, and you're going to have to choose based on as much diligence as you can get for that startup. Because think about it this way: in a larger company, you're going to get a very prepared experience. They've had many people like you come in, so they know what to do with you, and you're going to learn a very specific thing. You get a startup that's really moving fast with a great product, you're going to learn no matter what. The experience might not always be pleasant because the pace might not match what you want. Your role might not be exactly what you thought it was going to be. But this is where, ingenuity lies in this country. We have a startup culture in this country that is like no other in the world. Startups do amazing things, and more and more it used to be just entrepreneurship was just kind of, let's say, less predictable, but now there's a pattern. There are accelerators. There are railroad tracks for how you get from point A to point B. There are, opportunities like this one, which, caters towards entrepreneurship.
Sure.
So it's less risky than it used to be. Let's say that. And there's a lot of capital going into startup as well. So I'd say, as long as you're flexible and it suits your personality, if you're a self-learner, do it. You're going to learn a lot. Just take a close look first.
Yeah, and there are huge opportunities right here in Baltimore to join on with really exciting teams.
Yeah,
that's
absolutely.
Great. Okay, all right, good. So Sebastian, great job in the lightning round. That was really impressive. I think that was a great performance there. So let's go to some audience questions. We've got about 5 minutes left here, and Mark has fed me a good one. Any intention to focus on chronic diseases, especially where motivation and psychological outlook is an issue, like cancer or stroke?
Right. So we now cover asthma, diabetes, transplant recipients. We'll have our first COPD patient on the system, hepatitis C, HIV. So what I'll say about non-adherence is a very common characteristic of patients who are non-adherent can be depression, anxiety, and then also in some cases unrelated, but sometimes related, addiction sometimes. So yes, I think that psychology and the mental state of the person is very, very important, which is why adherence varies over time. So we've never tried, well, actually we do have a great project with the breast cancer team at Johns Hopkins, but it's not directly med adherence. Yes, I think that in any case where taking medication is important, a daily human touch, which is supportive and clinically informed, can really help the patient.
Okay, great. Got one more here that Mark's feeding us. What entrepreneurial resources in the region have you taken advantage of, and which one or two were the most helpful?
I think I've taken advantage of almost all of them.
I think you have.
I'm telling you, I don't know what other states are doing, but Maryland is pretty special. So TEDCO, the MII, I don't know if that's around anymore, plus then the seed fund. Then I had the accelerator programs from Dream It Health to Hopkins Fast Forward. Fast Forward was amazing. Fast Forward was great because, other entrepreneurs coming through and a team of people who are very professional, ready to help you at any time. The NIH, wow. I mean, there's no reason, it's a long game, it's a 1-year game.
Sure.
There's no reason that if you have something innovative, you don't put in a small business innovation research grant with one of these amazing clinician researchers at one of these institutions. So yeah, I think, what else have I taken advantage of? I think that's about it. I mean, I think office space is pretty well priced in the area.
A lot of variety, a lot of
options.
options.
Anything? Neil, we've known each other for a while. What else did I take?
Gosh, I think you hit the highlights.
Yeah,
you hit the highlights. That's great. Yeah, I mean, obviously I think you took advantage of everything appropriate for the stage Emocha was at and what its needs were at that time. So
you really have no choice. You have to, if you're starting out, you have to take advantage of absolutely everything that you can.
Yep, gotcha. Okay, Mark, any more questions coming in from the audience? I don't see any more on the. Oh, wait, here's one. Here's a general one. What other advice? What advice do you want to leave the audience with today? Any nugget of advice you can think of, or something that's really guided you over the past couple of years?
I think that being opportunistic in general, it's a double-edged sword, right? So sometimes you'll overcommit yourself, and but other times you'll find a great opportunity. I just feel that we're in a time of tremendous change right now, and that's obvious given what's going on. And I would just really encourage people to try new things right now, try new business models, try to think ahead a little bit, and be a little bit patient, because it's an unusual world we're in. But I think that whatever you do, I give the same advice to everybody who asks for it. You pretty much got to go as fast as you can, right? Speed is everything. And I think that defines companies, right? The definition of whether companies are successful or not is speed. Some people are really fast at raising money, and that makes them very successful. Others are very fast, like Emocha. We'll pivot if we have to. We'll be very determined and go very quickly. So whatever you do, be patient, but be fast.
Okay. Your UMB School of Pharmacy colleague, Dr. Rodriguez de Bittner, has a question here. Can you comment on the future of Emocha in patient remote monitoring? Area of growth for Emocha?
Absolutely. All, everything we could have asked for has been granted in terms of CMS reimbursement. So on the provider side, Emocha can be reimbursed and at a pretty good rate. So that's great. I think on the payer side, wow. I mean, we just proved that we can go to tens of thousands of people. I mean, I think at one point, about 2 weeks ago, we hit 1,000 people new enrollments in 1 hour. We hit number 11 on the iTunes medical app store for the day. So now, yes, I think we can monitor large populations and know how to scale the organization to do it. So yes, I think remote patient monitoring just got redefined by a pandemic. All patient care currently is some form of remote patient monitoring. So yes, Magali, I think that the future for Emocha is heavily remote patient monitoring, side effects monitoring, symptoms monitoring, medication adherence monitoring.
Okay. It's 2 minutes after 5. Jasmine and Mark are going crazy. Sebastian, thank you so much. Thank you so much for doing this. This was a fascinating conversation. I really enjoyed the interaction. It's awesome news for Emocha. So Jasmine, take it away.
Thank you, Neil. Thank you, Sebastian. I really appreciate it. Thank you all for coming to today's event. Like I mentioned, this is the second in a series of events that we're hosting for Chesapeake DHX Digital Health Huddles. I just wanted to give you a tip about next week. We have a really fun event that should get you moving a little bit, social with Burn Along, also a local startup that you'll get to hear from. So we really hope that you guys are able to make it to that event. Again, thank you all for coming. I want to thank our presenters as well again, Sebastian, Neil, Mark, and I will leave this up for a little while for you all to grab the link or check out any links you missed in the chat. Other than that, I will allow you guys all to see yourselves out. Thanks again for coming. We'll see you next week.
Thank you, Jasmine. Thank you, Neil. Thanks, Mark.
Thanks, guys. Have a great rest of the week. Be safe. Take care.